Yeah. Good morning, everyone. So, where do we stand? So, PSMA in this era, the diagnostics and therapeutics. So, what is PSMA? The prostate-specific membrane antigen. It is a transmembrane glycoprotein which is overexpressed in the prostate cancer cells. It is a theranostic molecule. So, what is theranostics? A molecule which is used both for diagnosis and therapy. So, for diagnosis, we label this PSMA with gallium-68, fluorine-18, and technetium-99. And for therapeutic purpose, we label it with lutetium-177 and actinium-225. So this is an illustration which explains how the radioactive molecule actually helps us in diagnosis and therapy. So this is the radioactive drug. So this is the so this is the radioactive drug, and this is the PSMA peptide, which are linked through a linker. And this is the prostate cancer cell, and which expresses this prostate-specific membrane antigen. And this is how we target this prostate cancer cells, and the radioactive drug, which goes with this PSMA peptide, emits the radioactivity, and we capture this through our camera. So we label this PSMA peptide in case of diagnosis with gallium-68, fluorine-18, and technetium-99. In case of therapy, we label it with lutetium-177 and actinium-225. So what are the indications? In the initial staging, PSMA helps us in the unfavorable intermediate and high-risk prostate cancer patients. This is a phase 3 multicenter randomized trial called the PRO-PSMA trial, where the PSMA PET-CT resulted in 27% greater accuracy of disease localization compared to the conventional CT-TAP and bone scan. So this is another two studies, the phase 2 and phase 3 multi-center study, where the PSMA PET-CT demonstrated higher specificity for the detection of pelvic lymph node mets in individuals with the intermediate and high-risk prostate cancer patients who underwent radical prostatectomy. This is mainly in relation with the sub-centimeter size nodes, which don't fall under the size criteria, where the PSMA identified the involved nodes. Next, the indication comes in the biochemical relapse or the biochemical persistent disease. So these are the two studies where there are multiple prospective studies which has reported a higher accuracy for the PSMA ligand PET-CT in the biochemical relapse, where they demonstrated a higher patient and regional level detection rates and the positive predictive value for the localization of this prostate cancer in the biochemical relapse setting. The next indication, the localization of castrate-resistant prostate cancer, just non-metastatic by the conventional imaging modalities. The PSMA PET-CT detects the local regional disease only in 44% and the distant metastasis in 55% of patients with non-metastatic CRPC and risk features. It detects the disease extent in patients with the non-metastatic CRPC with higher accuracy and leads to a considerable stage migration. Moving on to the prostate biopsy, how the PSMA guides in prostate biopsy. In those patients where the MRI is inconclusive, the PSMA PET-CT helps in better tumor localization and guides the biopsy in patients who had already multiple negative biopsies. So this is the image of a PSMA PET-CT, and this is the MR. When we fuse this to image, we will get a image which localizes the disease better, which helps in identifying the disease site to get a better biopsy who already had multiple negative biopsies. So next, the indication is for staging and assessing the eligibility of patients for lutetium PSMA therapy. So this is the pre-therapy diagnostic imaging, which showed a extensive peritoneal involvement. And these two images are the post-therapeutic images. After these images were acquired after giving the lutetium-177, where we can see the extensive concentration of this lutetium-177 in the disease mapped by the pre-therapy diagnostic imaging. So, and what is PSMA and what is the normal distribution of PSMA? This is an image which is showing the normal distribution of PSMA. It is secreted in the lacrimal glands and in the salivary glands, and it is excreted through the kidneys. So we can see the kidneys and the bladder. This is the normal PSMA image in a non-metastatic patient. moving on to the therapeutic side. So what are the current indications for PSMA therapy? Currently, it is mostly indicated in the metastatic CRPC patients. So the PSMA positive mCRPC patients who are progressing under at least one novel androgen axis drug like enzalutamide or abiraterone, and at least one taxane regimen, and are unfit or who are refusing the second line taxane regimen. So there is an international phase 3 RCT called the VISEN trial, which demonstrated the superiority of lutetium labeled PSMA 617 over the best standard of care regarding the safety, efficacy, and the quality of life. So the next indication is the PSMA positive mCRPC who progressed under the androgen axis drug and docetaxel, but would still be possible candidates to receive the cabazitaxel. So there's a 11 center phase 2 RCT trial called the therapy trial, which demonstrated a higher response rate, including the biochemical response and imaging response, longer progression-free survival at an equal median overall survival, and increased number of long-term responders at 12 months, and better patient-related outcomes in multiple domains, and reduced number of grade 3 and grade 4 toxicities with lutetium PSMA when compared to cabazitaxel. So the next indication is the patients with PSMA positive but taxane naive mCRP patients who progressed under at least one androgen axis drug. There's no option to participate in RCT or no alternative treatments available, or when they are contraindicated, it is reasonable and ethically warranted to give this lutetium PSMA therapy on individual patient-to-patient basis or in a compassionate care setting. So what are the contraindications against PSMA therapy? There is no absolute contraindication for giving this PSMA therapy. The relative contraindication is when the expected life expectancy is like less than 3 months. In this setting, we can give to alleviate these tumor-related symptoms, mainly the pain. And when there is an unmanageable urinary continence, even this can be tackled by using the urinary catheter and by reducing this radiation burden to the caregivers. And when the patient is having severe cardiovascular comorbidities, when the patient won't be able to tolerate the hydration, which we give with this lutetium PSMA therapy. So the other relative contraindications are when there is a risk of multi-organ failure, when the GFR is less than 30 ml, when the creat is high, more than 2-fold the upper normal limit, and the liver enzymes are more than 5-fold the normal limit. Myelosuppression. So initially there was a consideration that when there is a risk of myelosuppression, we tend to avoid PSMA therapy. But in recent times, we have treated multiple patients who had extensive skeletal disease. After giving PSMA therapy, we have found in like a significant number, there is the counts begin to improve after we giving the PSMA therapy. So who had an extensive skeletal disease. So now we can give lutetium PSMA even though there is a risk of myelosuppression who have extensive skeletal disease. Only thing is we have to closely monitor the blood cell count. So this is a PSMA post-therapy imaging in who had extensive metastatic disease. And this is another patient who is metastatic, but this patient is not eligible for therapy because here, if you see, there is a supraclavicular node, axillary node. I mean, there are the multiple retroperitoneal nodes, and there is an acetabular lesion, which didn't show significant PSMA expression in the diagnostic image. So this patient is not eligible for this lutetium PSMA therapy. So what is the treatment schedule? We give 200 millicurie of lutetium 177 PSMA at an interval between 6 to 8 weeks. We can continue up to 6 to 8 cycles depending on the patient tolerance. And we do response monitoring after every 2 cycles with a gallium-68 PSMA PET CT. So we give around 8 to 10 ml of lutetium PSMA mixed in 100 ml of normal saline. We give as a slow infusion. It can be injected as a direct injection also. But that might lead to slight patient inconvenience because this alcohol-based radiopharmaceutical might give irritation in the IV line. So this is how we give PSMA therapy in our ward settings. So this is given as a slow infusion over 15 to 30 minutes followed by hydration. So this is the post-treatment imaging. On the left side, we can see the anterior and posterior image of the pre-therapy diagnostic imaging. On the right side, we can the post-therapy imaging where there is a significant concentration of lutetium-177 in the extensive peritoneal disease. So the treatment-related toxicity, mostly this lutetium PSMA is tolerated very well. The most common side effect from the lutetium PSMA trial is dryness of mouth, followed by transient nausea, fatigue, and thrombocytopenia. And the therapy trial, the grade 3-4 adverse events occurred in 33% of lutetium PSMA group compared to the 55% in cabazitaxel group. So what are the ongoing important trials for this PSMA therapy? First one is the LU-PSMA trial. This is a single-arm phase 2 study in CRPC patients who progressed after the standard taxane-based chemo and anti-androgen drugs. Results are like 57% showed more than 50% decline in PSA and 87% with objective response in the nodal or visceral disease. Then the therapy trial, this is a double-arm phase 2 study. Patients, MCRPC patients who progressed after docetaxel, who are eligible for cabazitaxel. The lutetium PSMA showed more than 50% reduction in PSA, in 66% in the PSMA arm and 33% in the cabazitaxel arm. And this is the most important trial, the VISION trial. This is a double-arm phase 3 trial. In the MCRPC patients who progressed after the ARPAs and 1 or 2 taxane-based chemotherapy. The LU-PSMA, the overall survival in the PSMA group was 15.3 months, while with the standard of care, it was 11.3 months. And the imaging-based PFS with the PSMA group, it was 8.7 months, and the standard care was 3.4 months. And the interim result of PRINCE trial, this is a phase 1b2 trial where lutetium PSMA is given with pembrolizumab. The MCRPC patients who underwent at least 1 ARPAs or taxane-based chemotherapy. Here the results are, there is a PSA reduction more than 50% in 73% patients, and the overall response rate was 78%. So other ongoing trials were the upfront PSMA, where in the hormone-sensitive prostate cancer, where PSMA therapy is given along with the chemotherapy, and the eutectomy trial for in patients who have localized disease who are eligible for radical prostatectomy. It's a single-arm study. 2 cycles of lutetium PSMA is given before the surgery. The other trials are PSMA-4 in a hormone-sensitive setting after a first line of ARPI, and then PSMA addition. This is a phase 3 trial, same as like VISION trial, and the ENZA-P trial in the hormone-sensitive prostate cancer, where the PSMA therapy is given along with enzalutamide versus enzalutamide alone. And coming to the newer radiopharmaceutical, this is actinium-225. This is an alpha particle emitter. This has a shorter penetration compared to the beta-emitting lutetium-177. So there is a possibility of lesser marrow suppression. And this can be considered in patients who have an extensive skeletal disease, who have a higher risk of bone marrow suppression following lutetium PSMA. So this is a recently published paper, a multi-center retrospective study with 488 patients with the MCRPC. 1,174 cycles of actinium-225 has been given to these patients. The median overall survival was 15.5 months, and the progression-free survival was 7.9 months. And the dryness of mouth, xerostomia is the most common side effect, and the marrow and renal toxicity are the less common adverse effects. And currently, the actinium-225, the availability is an issue, but in the upcoming days, it is going to come in a bigger way, so which will help us in these patients. And all these 488 patients had already received one kind of nuclear medicine therapy. Either they have received lutetium PSMA, and someone has received even radium therapies, and who had myelosuppression after receiving lutetium PSMA or other kind of therapies have been included in the study, and they have showed a better response. And actually, it was my best friend and my former colleague, Dr. Varun Shukla, who was about to give this talk, but unfortunately, in the last minute, he was unable to make it to Banaras. So thank you on his behalf and his institute, HPC RC, New Chandigarh. Thank you.
Excellent talk. I have a question. In the era of the PSMA PET scan, is there any role of the bone scan? Or are there any fallacies of the PSMA PET scan where bone scan can be indicated? Actually, both are available.
Bone scan, it is a 2-dimensional modality. So many times the bone scan is the basic mechanism behind the bone scan is the tracer will go to the sites wherever there is a new bone formation. So even some benign conditions, if there is a some kind of where there is an increased bone turnover, this MDP will go and localize there. So it the sensitivities, the specificity is actually less with bone scan, and it is a 2-dimensional modality. With PSMA PET-CT, we give a three-dimensional cross-sectional image. So we can localize the exact site of the disease, and you can even analyze whether like the CT morphology, if there is any, if there is extensive disease, we can look for any chances of cord compression. So it gives a better detail than the bone scan.
Are there any false positive diseases in which this PSMA PET scan can show false positivity?
In case of bone, you are asking, or like other
PSMA PET scan.
No, PSMA PET-CT, it is you are asking about the bones or in other structures.
False positivity in viscera.
Yes, false positives can come many times in normal scans. Also, we can see the physiological uptake in the gallbladder. Sometimes the renal lesions might show uptake. Even the RCC sometimes show. We have found patients who had incidentally detected renal lesions which were like positive with PSMA. So we use only in the intermediate and high risk cases we use. Otherwise, we don't use. Yes, for local staging, MPMRI is better. In those cases where like there is inconclusive biopsies, this can help to localize the site. Otherwise, for the local staging, MPMRI is best in identifying the seminal involvement and to guide the target the biopsies. PSMA is better in identifying the local nodes which does not fall under the size criteria with the CT. So there it helps. The sensitivity of PSMA is more in identifying this sub-centimeter size nodes.
Yes, the parametric nodes positive, which may not match the clinical situation.
Like same like the CA cervix here.
So that's why because of the higher sensitivity of the PSMA PET scan, till now, especially in the guidelines, PSMA is not the upfront modality for staging, but
now it is like
it has taken as a sort of upfront modality, but still PSMA PET
now it is like advised if it is available now in high risk, it is intermediate.
PSMA PET scan is more of whether distant metastasis localizing disease.
Yes.
And in America, the trials are going on from the Mount Sinai, whether they are studying if PSMA PET scan can be labeled as a initial.
Recently, it is approved by FDA, so just now they have started.
They are doing, they are hearing us, so they are not.
Yes.
हमारे यहाँ पे क्या है कि कुछ ऐसा रेगुलेटरी चीजें हैं नहीं, तो हम लोगों ने क्या है बहुत पहले से आई थिंक 10 साल पहले से ही RTCI and other private ones. So I will discuss the reverse story. If the US would have been initially done, they would have propagated all over the world. Since they don't have nucleotide, they are telling us not to do. And in due course of time, next 5 years, they will say that do it. So we are far away from that. And like a story of I do lung also. So in a lung cases, if FDG without a FDG positive doing a FDG, you can't go